but I am going to introduce our speakers now. So welcome back, Dr. Danielle Anderson. She received her medical degree from the University of South Carolina School of Medicine in Columbia, South Carolina. She completed her family medicine residency in the University of Kentucky Rural Tract, spending her last 2 years of residency at St. Clair Healthcare in Moorhead. She is board certified family medicine physician. Dr. Anderson completed a fellowship in addiction medicine at the University of Kentucky and now works in the UK Department of Psychiatry as an addiction specialist addressing all types of substance use disorders. We also have back Nick Kimberlain. Nick is a person in long-term recovery from both alcohol use disorder and substance use disorder and works as a peer support specialist in the University of Kentucky Psychiatry Department. He was formerly employed with Voices of Hope, a nonprofit recovery community center in Lexington, Kentucky, and now serves as the head of the Community Advisory Board. He has been doing peer support for approximately 2 years. He has also started what is now the only in-person MARA, Medication Assisted Recovery Anonymous meeting in Kentucky. Every day he wakes up and gets to work his dream job. So welcome back, Dr. Anderson and Nick Kimberlain.
Nick and I don't have any financial disclosures. So we'll go over the practice gaps first. Prior to development of FDA-approved medications for OUD, 12-step programs provided one of the only options for treatment. And as the prevalence of opioid use disorder and opioid-related deaths have increased, so have the need for treatment that addresses the biopsychosocial aspects of the disease. So looking at the disease from multiple treatment points. Patients with opioid use disorder taking evidence-based medications may face challenges when integrating their medication with traditional 12-step programs whose definition of abstinence conflicts with taking medication to treat substance use disorders. There has been, as we discussed last time, relatively little research into the patient experience with traditional 12-step programs and MOUD. However, common challenges have been identified, and we'll review those again today. And understanding the common challenges for patients on MOUD can empower providers, our social workers, our peer support specialists, and other people in the community to help patients navigate strategies for integrating their medication into mutual support groups. For our learning objectives, we're gonna review at the last meeting we reviewed similarities and differences between common 12-step and mutual support programs, and we'll do that again today. We'll explain common challenges and review the challenges that we talked about last time that persons on MOUD face when integrating medication and abstinence-based programs. And we'll explain strategies for integrating MOUD and explore alternatives to the traditional 12 steps. And we're hoping that you'll be able to exchange at the end of this program, you'll be able to explain the challenges and barriers to participating in abstinence-based programs for patients on MOUD and help people be able to navigate what strategies or programs fit their need. So for our talk today, we're going to review some of the key points from our last talk. We'll answer questions that were sent in, and then we'll wrap up with some case scenarios and get ideas on how you all would handle the situations that we're setting forth and some key points we think people need to know for handling certain situations. We encourage participation and we welcome comments and questions. Please just remember that on our KY open sessions are recorded, so don't use any identifying information about patients if you're going to comment or tell us a patient story or situation that you've had. Okay. So we looked at this slide last time Principles of Effective Treatment. And this is a document made by NIDA to guide practitioners and anyone who works in recovery on the different aspects of recovery and what our goals should be. So these principles of effective treatment focus really on the need to create a treatment plan that is tailored to the individual. The keys are here that treatment should be individualized and reflect the needs of the person in recovery, and that periodically treatment and services plans should be reviewed and modified to meet the patient's changing needs. So what they needed in the beginning may be different than what they needed when they're well into their recovery. NIDA recognizes that medications, support groups, and counseling and behavioral therapies are all important aspects of treatment, and they may be used more or less at different times during recovery. Next slide. So just to review our comparison of the 12-step and mutual support programs, we kind of looked at AA and NA in the same, as having a lot of similarities. And so AA and NA both follow the 12 steps and 12 traditions and are spiritually based programs. They're both abstinence based, and sponsorship is required to do step work, and they both highlight the need and importance of service while you're in the program. MARA is another 12-step program that is not spiritually based. MOUD is accepted. Sponsors are not required. And again, it's not spirituality based, but some of the 12 steps are very similar. Smart Recovery is a 4-point recovery system. They welcome MOUD. It's based in the science of recovery, and also is not spiritually based. And then we have Celebrate Recovery meetings across, which is also an international meeting like the rest of these, which focuses on the 12 Christ-centered steps and 8 traditions that go along with the 12 Christ-centered steps. Next slide. Like we talked about last time, patients receiving MOUD face a lot of challenges. And although this has been difficult to study, there have been studies that have identified common challenges for patients on MOUD in traditional 12-step programs. And many of you shared stories and comments last time, really supporting a lot of these challenges that have been identified. And I think that this is something that is continuing to be studied and is going to be very important to keep identifying the challenges and then trying to find methods to both deal with the challenges and perhaps even push at some point to have more access and acceptability of patients on MOUD. And while we also discussed that AA and NA are abstinence-based programs, it's important to remember, and both of these programs cite in their literature, that individual groups may have different opinions. So individual group meetings may have varying opinions on the use of MOUD, and they are autonomous in that way. So just to review some of the challenges, we know that patients receiving MOUD have been told that buprenorphine maintenance is a crutch, that they're not truly sober, that methadone and buprenorphine are trading one drug for another, discounting recovery or clean time while patients are on MOUD, and prohibiting MOUD users from speaking at meetings and holding leadership positions. Many of these patients have said they have the ability to attend meetings but not participate in the step work, or they have difficulty finding a sponsor. And members have experienced pressure to stop MOUD or to taper early before they're ready. Next slide, John. So we took a look at this study, which is a really interesting study that was conducted using interviews to really pinpoint what stigma people were facing at these meetings and how people are people in recovery who are on MOUD are managing this on their own. And so this study by Andraka Christo, they were able to interview 30 patients that were using MOUD and also participating in the 12 steps. And in this study, they identified many of the things that we just talked about. Not being allowed to speak at meetings, encouraging shortening of the time on MOUD, describing MOUD as not in recovery, and refusal to sponsor individuals utilizing MOUD or prohibiting those receiving MOUD from being sponsors. And so this I really think is the first step to moving forward, having studies like this that identify what the true issues are, and then getting those issues out there so that we can find ways to manage this with our patients, and maybe even create in the future, like I said, more programs that are accepting of MOUD or promote acceptance of MOUD. Next slide. We talked about last time our cognitive approaches to avoiding internal stigma, and these are by no means approaches that you have to use with your patients. It's really going to depend on the patient's personality. But what this points out here are ways that people who are currently trying to manage receiving MOUD, dealing with stigma, and going to abstinence-based 12-step programs have used. And it may work for one person, but not for another. One of the most important, I think, is using the knowledge of MOUD based on experience to decide that anti-MOUD statements are false. So helping the patient realize that abstinence, this definition of abstinence, is really a personal definition. Many of you gave great definitions and your personal definitions of abstinence in the last meeting, and most people agreed that abstinence was really not using illicit opioid medications or obtaining them from illegal means. And so by reviewing this stuff with the patient or reviewing the number of drug screens they've had that are negative for illicit opioids, can kind of prove that, yes, you are in recovery. And those statements are actually not true. People tell you you're not in recovery or using it as a crutch, or that's not true. And it really depends on the individual's truth and what they believe, but helping patients realize that can be helpful. And also ignore negative statements while accepting that any group will include some people who are ignorant or mean. Now, this is directly from the study, but I think we can even look at that with our current state with the pandemic right now. We do have to recognize that each person has individual beliefs about the pandemic, how it should be managed, and we all have to accept that our neighbors, our friends, our patients may not have the same views as we do, and that's okay. The third is perceiving MOUD related stigma as contrary to the 12-step tenets and thus truly not representative of the 12 steps. And some people in recovery on MOUD truly believe that anti-MOUD statements or negative thought processes towards MOUD in general really don't hold with what they feel the 12 steps represent. Sorry. So we're going to take a look again at the facts that we discussed at the end of our talk last time. And Nick and I are going to kind of give you some examples of how we would respond to these frequently asked questions.
Yeah, so the first one is, am I required to speak at AA or NA meetings? And the answer to that is no, because, or actually, in fact, newcomers are encouraged to, to sit back and listen and take in some knowledge. And the next one, do I have to be a Christian to go to AA or NA meetings? Absolutely not. AA and NA do focus on that higher power. So the higher power is very important. It's a pillar of, the group. But that higher power can be anything you want it to be. It could be a doorknob, or it could be your mom or the group or anything, starting off. So definitely don't have to be a Christian. And what meetings are friendly to people prescribed MOUD? Obviously, MARA and SMART welcomes patients as well on MOUD. But as Danielle said earlier, the acceptance of MOUD can vary from group to group in traditional 12-step AA meetings. And yeah, do I have to tell my sponsor that I'm on MOUD? It's a personal choice, that each person's free to make, for themselves, and then maybe ask them what concerns they have about sharing, and just tell them to remember that decision is between, them, the patient, and the doctor, and that's it. It's not a decision for anybody else to make ever. So it's a very big step for someone taking medication, as most of us know, to stop or taper, and it should only be talked about with their doctor. Next slide, please. Thank you. I'm not spiritual. Are there any recovery programs that would work for me? Yes, absolutely. MARA and SMART are not spiritually based at all. Both MARA and SMART also state that spirituality or religion is not discussed in our meetings. So what should I do if my sponsor tells me I need to stop taking it? So everybody has different needs in recovery. And before stopping, absolutely 100% discuss it with your prescribing trusted physician. That is, those are the only people that we can trust fully with our. And do I have to have a sponsor to work the AA or NA steps? Yes, you do. Sponsorship is required in AA to work the steps. Usually it's someone of the same sex who's worked the steps and has a sponsor. Next slide, please. Or actually, do you guys have any comments on the last two slides or any of the FAQs? John, yeah.
Just summarizing again, our talk from last week and some of the key points. We know we've now identified challenges in traditional 12-step programs for those receiving MOUD. We know that environments that stigmatize MOUD may cause our patients and clients to feel anger, pressure to taper off MOUD, search for alternative programs and more accepting programs. We know MARA and SMART Recovery are two programs that are accepting towards patients on MOUD, and that providers, peer support specialists, our social services, those working in social services can help people navigate the challenges and offer support to patients on MOUD. We can talk with them about negative feelings, about being more knowledgeable about alternatives in our practice area. So Now we're going to answer some questions related to our talk from last week, and we'll also talk about some case scenarios and get your opinion on how you would manage situations with these patients and clients. So, what is the role of a sponsor? And Nick's going to talk to you a little bit about what the role of a sponsor is and how they can help people receiving MOUD or even people not receiving MOUD achieve long-term recovery.
The role of a sponsor, it's going to be somebody that you pick that you trust fully and absolutely, because you're going to be going over a lot of things, a lot of personal, very uncomfortable personal things with that person. And that, is just to help you get past them and help you work it out. Then they're also there to teach you coping skills and, to be there to answer the phone to say, hey, how are you doing? How was your day? Or you can call and tell them how mad you are about something and how it just makes you want to scream, and they're there to guide you through that. Excuse me. And also to identify and recognize, thought processes and behaviors that threaten recovery. Like, next slide, please. Yes, do you guys have any comments about the role of a sponsor, or what you think the role of a sponsor is?
I'll just mention that there's actually some data to suggest that folks who are on MOUD and are engaged with AA or NA and have a sponsor may have improved retention rates as well. And so as a clinician, I'm often asking, where are you at with the meetings? Do you have a sponsor? That sort of thing. Not necessarily to push them towards a sponsor if they're not ready to reach for that, but really to try to understand what are they getting out of the meetings. And certainly having a sponsor appears to be associated with some improved retention and care.
Okay.
I have a quick question
Yeah.
for you, Nick. So I know we talked about how NA and A are different in that like Smart Recovery and MARA don't have sponsors, or they have optional sponsors. Do they have that mechanism in place if they want it? Because given Devin's point that having one person to be accountable to can be helpful, what are the options for those other meetings, or are there not those things?
Yeah, and in MARA, Medication Assisted Recovery Anonymous, sponsorship is completely up to you. If you don't want to have a sponsor, you don't have to have a sponsor. You can work with what they call responsible others. And that's to talk with and get advice from everyone in the group when you're working your steps. Because some steps are required that you working with someone else, and of course you would need that for those, but it's open to letting you just get advice from everyone instead of just one person if you want to. Now you can have just a singular sponsor in MARA as well. Now, as far as SMART, there is no sponsorship. They rely on the group. The whole group of people every week, and they say that they don't encourage or discourage relationships outside of the meeting room, but while we're in the meeting room, everyone is involved, and everyone's discussing everything with each person. Yeah. All right, if nobody has any comments or questions, we can go ahead and move on.
Next slide.
Yeah.
Okay, so this question was, what is the current thought on legality of judges or other officials requiring attendance at AA or NA meetings given their religious connotation and underpinnings? According to, I did a little research on this question. According to the Kentucky Administrative Procedures of the Court of Justice, Part 13 deals with regulations surrounding the drug court system. And Section 10, particularly of this this document, deals with drug court participant requirements. According to this document, persons within the drug court system are required to attend a self-help program, and that is the language that they use. And they go on further to say such as a 12-step program, but it does not necessarily designate acceptable or required programs. This could vary by county, and I'm interested to hear if anyone has had experiences with clients or patients who were required to go to 12-step meetings that had some sort of religious component, or any other program, self-help program with a religious component, with patients who may not be spiritual. Has anybody had that experience?
I mean, I'll have to say, this is Nick, but I was a participant myself in the drug court program here in Fayette County for 3 years, and you're right about mutual or self-help or whatever they call it. You do have to go to those, but they do give you the freedom to pick and choose, or which one you want to go to. So it doesn't necessarily have to be AA or NA, but it's definitely encouraged. And I will say too that going into it, I knew that I was going to have to go to mutual support meetings or self-help, and I really didn't want to at first, and I really hated it. But from being forced through drug court, I think it helped me get my footing in recovery, and it helped me figure out who I was, who I am. So just wanted to share.
One other comment I'll make about this doesn't necessarily deal with mutual support meetings, but I previously worked in a rural county, and I took care of patients in my family medicine practice who were court ordered to go to residential treatment, and some of these patients were court ordered to go to residential treatment that either did not support or allow MOUD or were Christian-based programs. And I think if we look back again at that NIDA principles of effective treatment, our goal is to help people achieve long-term recovery and lasting recovery. And if we want to do that well, we really need to identify their individual needs. And that's something that I think we need to work on advocacy for in our state. I am encouraged by the language of this document that says self-help programs such as AA or NA, and the fact that they did not define that each individual has to attend a certain program, but we could certainly expand on that and match our patients and clients to treatment programs that fit their individual needs.
I'd like to chime in on this from a criminal justice perspective, just some of the work that we've been doing and learning with our various partners, especially drug court agencies, and talking with some of our peer support specialist agencies at ART and Voices of Hope. What we've learned is exactly what you said here, is that the different kinds of group meetings, it's not specific to NA or AA in terms of any of the statutory language, but in some cases, judges or attorneys, as part of the different deals that they're putting together for each individual client, will also want to see those sponsor meetings happening. That will be a specific part of that. So I think it's really good for us to keep in mind that with the different configurations of SMART and MARA, that there are opportunities for sponsor type relationships to be set up if that's a part of what the client is required to have with those court deals. And another thing that I wanted to mention related to different kinds of providers who are available to folks involved in the criminal justice system is that we're currently working on the CJ team in a protocol for our implementation facilitators to reach out to the medication for opioid use providers with whom they're currently partnering on linkage and retention activities to give them information about a program I'm going to put out in the chat here, information about it in the chat here. It's a program associated with House Bill 284 that's allowing for different levels of program good time credit based on completion of an approved SUD program as appropriate and referred to by the Division of Addiction Services, Social Services clinicians, like several of our colleagues on the call here who work in that area. So we're working on collaborating with our medication for opioid use disorder providers who are involved with the Healing Communities study to give them information about this opportunity to be on the approved list of providers for folks who would be receiving program good time credit that would potentially reduce the length of a sentence or of community supervision time under probation and parole for participation in all different kinds of treatment, including medication assisted treatment is one of the 3 levels of care that they allow for here. So totally agree that there's a lot of opportunity for advocacy and education of judges and folks on the prosecutorial side, especially through the work of alternative sentencing workers, right? Those folks who are working with defendants, indigent defendants who might not be able to afford counsel, and that's, often most of our clients. Alternative sentencing workers can be very effective advocates for different kinds of plea deals that might include the very most appropriate treatment options. So that's a great opportunity that we're continuing to explore with a state level meeting with the alternative sentencing worker program coordinator. See that as a great opportunity for intervention. And one last thing I'll say is the ASW program is relatively new. It's something that was instituted back in 2015. So again, with the Healing Community Study, we're really hoping that we can develop good, strong partnerships with those folks who are working on the defendant side on various kinds of pre-sentencing deals related to treatment.
Thank you so much, Margaret. That was a great update. Really appreciate you sharing that with us. I'll just one more word on this topic is that access to programs in some of our rural, or access to meetings in some of our rural counties may be limited, and so patients in the drug court system may be very limited as to what meetings they're able to attend due to transportation or ability to physically attend a meeting. So that's another barrier that we need to overcome, and may be able to overcome some of that with virtual meetings, which we will talk about in maybe the next slide or a couple slides. Any other comments or questions? So, do self-help groups just focus on substance use? In groups or meetings, can people get help with other areas of their lives? Do groups help people get access to resources they might need? So both Smart Recovery and Celebrate Recovery, their program descriptions include dealing with other situations in life that people may need to work on or overcome. And so in terms of looking at something like codependency or other self-destructive behaviors, maybe food addiction, problems with things like binge eating, those are all examples of focuses that can be used in both Smart and Celebrate Recovery. And it may be that people receiving MOUD or patients with opioid use disorder may want to work on multiple aspects of their life. And so both of these programs offer the opportunity to do that. With Celebrate Recovery, there are meeting specific and topic specific small groups that are smaller groups that patients can attend, and one of those groups might be a substance use disorder group. One of those groups might be a codependency group. One of those groups might be something like a relationship with food group. And so you can tailor some of these programs to other aspects of your life. Nick, do you have any additional comments? We may have lost his.
No, I was on mute. I mean, not really. That pretty much covered it, what you said. I really like the fact that you can go, you can go to Smart Recovery and discuss your problems with substance use, and then also someone else has like a problem with gambling or shopping, and you can kind of see and relate to what they're saying, and I think it kind of shows us that our struggles are relatable.
There's 4 key objectives to smart recovery, and one of them is living a balanced life. And so at least a quarter of the time they're focused on how are we balanced, what are the parts in your life are going to be helpful in your recovery. A lot of the sort of linkage to other resources happens just peer to peer, right? I've been going to this program, you should check it out as well. Or here's how I navigated sort of getting food stamps linked back up. So some of that is just part of that, being in that social environment and connecting with others that can be crucial work in recovery.
Okay.
I haven't seen a Celebrate Recovery yet that would turn down somebody, on MOUD. I mean, they're about helping everybody. And most of the time they try to match somebody that's got the same situation. And this is with, the leaders, small group leaders and things like that. And I think that really works because to me, the connection is everything. And that really works right now. I'm starting to see that there's a lot of these guys that have been around NA for a long time that have these sober living houses are now doing, doing the Sublocade and the Vivitrol, but they're kind of shying away from the pills a little bit because of the chances to sell those and do other things. But say it's changing, and I'm glad it's changing.
Well, Tom, thank you for your comment. And it sounds like you've noticed that there can be camaraderie and support for different aspects of our patients' lives in Celebrate Recovery. And we'll go to next slide. So what is the best way to check in with your client or patient on their mutual support groups? And I noticed this in several studies, conclusions of studies and suggestions for what physicians can do to really help mitigate some of the stigma and understand what their patients are going through. And one of the most important things we can do is just ask the question, ask patients about their experience in 12-step groups, offer support and validate feelings. It's really, really important to listen, do some active listening, and let patients know that you're aware that they may be facing challenges, and not just kind of gloss over that and let that opportunity pass to connect with your patient in that way. And you can also navigate negative or incorrect information about MOUD if patients feel they're experiencing stigma. If they feel they're experiencing stigma related to negative information about MOUD, or people have incorrect information saying, oh, it's a medication you have to be on for the rest of your life, you're trading one drug for another, really addressing each one of those statements individually so the person can either kind of avoid internalizing that stigma or know how to answer questions about MOUD if someone asks them about it. Any comments or questions on this?
Yeah, Danielle, I just echo the importance of really practicing this. So will often do sort of role play. Let me be sort of the the stigmatizing or obnoxious participant, and you be you, and let's practice what you might say if somebody approaches you or just brings up this topic, because then they can get it all out there. They can practice some of that language to push back against stigma, and that's going to help you build that relationship with the client as well.
Yeah, thank you for that. Thank you for that comment. And that's a great way. I think someone mentioned on our last talk that people hear about the stigma related with going to certain recovery meetings, and they may avoid going altogether. And practicing with your patient or client may give them a feeling of security and decrease some of that fear they have about going there and experiencing that stigma. Next slide. How has the move to virtual meetings changed mutual support groups? Are virtual meetings as helpful to the patient or client? Do you feel virtual or hybrid meetings will become commonplace? So this is an extremely important point to bring up, since many aspects of recovery have had to adapt to health precautions during COVID-19. And we're just now seeing the studies looking at some of the movement to virtual treatment and virtual meetings. And the shift to online meetings has received a lot of praise because this has increased access for many without local meetings, for people without transportation, for people with physical disabilities who are unable to even get to a meeting. And it has even allowed some patients with social anxiety to feel more comfortable because they're not sitting there in that room. But for some people, attending a meeting in their hometown is also a barrier. So it's allowed people to connect via meetings throughout the world, the country, other places in the world. I have a patient who attends a meeting in Florida. I have another patient that attends a meeting in Australia, and it really highlights that singleness of purpose that people all over the world are trying and are working together and have the same experiences. So there can be a lot of camaraderie and validation in doing that. The downside has been that many people are feeling less connected, more isolated, less engaged. And people in rural communities are particularly maybe affected by this. Some may be able to attend more meetings, but others don't have a reliable way to connect to the internet or electronic means that can connect to the internet. So my hope for the future is that people will be able to attend however they choose. Nick currently runs a MARA meeting that is hybrid and involves both in-person and a virtual component. And we've talked about it in the past, and he feels people really enjoy that. It is also possible, though, that some people will become less engaged when they don't have to get up and do that physical action, because sometimes that's part of a daily routine or part of what they do for recovery that day is the actual action of getting up and getting to the meeting and, seeing smiling faces, providing that service aspect that we talked about with NA and AA. So I think there are benefits and there are some downsides, but I believe it really depends on what the individual patient needs are. Anybody have any comments on how on this, or things they've experienced or their patients or clients have experienced with the virtual versus the inpatient or in-person meetings?
So there's a question in the chat about do we know if virtual meetings count towards drug court?
That is a question I do not know the answer to.
I answered it in the chat just now.
I'm sorry?
I just answered it in the chat.
Oh, okay.
They do, I know, in Fayette County for sure, because I've had experience there. And what they ask is that you take a screenshot of yourself in the meeting room,
Okay.
which is also I don't know. Some people don't like that because of anonymity and everything, but that's, I guess, the best that they could come up with on short notice, you know. And also, like as Danielle said, I do run a hybrid meeting. The MARA meeting is hybrid, people in the room. Usually, you know, we have anywhere from 3 to 10 people in the room, and then anywhere from 6 to 25 people online, and they're from Florida and Iowa, North Dakota, California, Kentucky, Indiana, Australia, and it is great to be able to come together with all those people and just have a discussion about what's going on in their lives. I think that the hybrid meeting has made, I know my MARA meeting at least, it's been great. People they build relationships and bond, and everybody feels really close in that meeting, even though over half of them are online. We look forward to seeing each other every week.
And Margaret put in the chat, it's her understanding that if the meeting facilitator supplies documentation in the same way that is required for in-person meetings, that these meetings can be accepted. All right, we'll go on to the next question. With medication as treatment promoted rather than medication-assisted treatment, do you feel recovery groups are threatened due to lack of mandates of recovery groups associated with MOUD? What are your thoughts on medication as the sole remedy for addiction? So for this question, we're going to refer back to our principles of effective treatment. I do think the change from medication-assisted treatment to medication as treatment does not necessarily mean that medication is the only treatment that someone can use to achieve long-term recovery. And this change, I believe, has been made to decrease stigma around MOUD and accessibility. And while I can't speak to whether groups feel threatened, in an effort to decrease barriers that prevent people from having MOUD, many programs do not require recovery groups. And so that's where that recovery mandate has changed for many programs. And while I believe providers hope to help people achieve long-term recovery, we also know that buprenorphine saves lives and decreases risk of overdose. And many providers do not want to decrease access to a long-term medication just based on someone's ability to attend recovery groups. So do I think it's the sole remedy for addiction? For many patients, no, it's not the sole remedy. We all know that there is a psychosocial aspect of addiction. But again, we don't want to limit access to a life-saving medication to our patients. Devin, do you have any comment on that?
I want to hear other people's thoughts on this before I jump in, but I certainly echo your sentiment that the last thing anybody wants to do is close doors that would get somebody into treatment and into long-term recovery. So really, I would hope that recovery groups don't feel threatened by us using medications for opioid use disorder in the same way I don't feel threatened by groups that are not using stigmatizing language, that are making sure that folks feel welcome and opening more doors to recovery. The last thing we need is closing more doors at this point.
Any other comments?
One thing I've done recently, using the slides from Dr. Orla here with the 50-50 waiver, about explaining to some of these people in NA and AA, the science behind it. And most of these guys that have really stepped forward in this have, 7, 8, 9, 10 years in recovery. And they've seen things change with the different drugs and the different things that are out there right now. but they're all for it, but they're doing it one by one, working with people or in groups of like-minded people versus taking it into traditional meetings such as NA or AA. I don't know when that's going to change, but at least it's starting to change. And I think it's critical because, that connection is what keeps us, that keeps us going the right direction, knowing that we've got somebody that we can always call, that we can always talk to, that will hold us accountable and that we can hold them accountable. Somehow that works way more. It worked way more for me than anything else, but that was quite a while back. But that's what I took from the very beginning, and I still see it right now.
Yeah. We look a lot at treatment from a biopsychosocial aspect, and a medication really addresses that bio part. We know that medication here can decrease cravings, it can decrease withdrawal effects, but medication may not be the sole factor that changes behaviors. And we know that behavioral therapies are a very important part of recovery. Again, I do think it has to be individualized, and people may be more ready at one time or another to engage in additional aspects of recovery. In fact, in my practice, where I'm dealing with substances other than opioid use disorder, I oftentimes have people who are ambivalent about attending mutual support groups when we first start talking, and as they start trying to navigate their recovery, they quickly realize that they need that social support, and they need those skills that they learn through recovery groups. So just because someone initially is not interested in going to a recovery meeting doesn't mean that they won't change their mind about it. Any other comments? Okay, next slide. And again, I know I keep harping on the principles of effective treatment, but this is such an important concept. Sometimes we want to fit people into a box and say, oh, if you'll attend meetings, if you'll take this medication, if you'll go to counseling, everything's going to be great. But we have to start thinking about it as an individual treatment program, and asking the patient what their needs are, and then matching our treatment plans and our recommendations to what that person needs to achieve long-term recovery. Next slide. So here's the case scenario. Really would love to hear everyone's input on this if you have a comment, and there are no wrong answers. Comments help all of us shape the way that we manage patients. So a 40-year-old male patient with opioid use disorder presents to the office for a buprenorphine induction. When you begin discussing mutual support groups, he states, yeah, I have heard about those meetings. I'm a very private person and they will not work. They will just not work for me. How would you respond to this patient?
As a peer support, I would just say, when I was using, the more and more I used, the less and less I wanted to be around other people. But as in my recovery, I found out that making these connections with other people have made the most difference in my life. And I actually do that. I kind of bring that up right in the intake and admissions.
Okay. Thanks, Tom.
And I feel like early recovery especially is about kind of getting out of your comfort zone, doing things that make you uncomfortable to further, better your life. I think anyways. I know when I first was trying to get in recovery, I did not want anything to do with groups of people or getting to know anyone, but if you go and get out of your comfort zone, I think it becomes easier and easier. And then you can, at least me personally, I kind of crossed that over into everyday life, and I was able to talk with people easier and a lot of other things too, good that came out of that.
Well, I think you make a valid point there. Recovery initially, and sometimes even far into recovery, can be uncomfortable. So maybe highlighting that. Nina said in the chat that she offers virtual meetings, and I think this is a great option that we really didn't have a little over a year ago for many patients. Mina, do you know if any patients that you've sent to virtual meetings ended up going to in-person meetings or ended up continuing to go to virtual meetings? What has their response been?
The ones that I have that are doing aftercare are the ones that I really pushed the meetings on to keep them in that state of mind that they were in. And with the COVID, then we had to pretty much all virtual because most of the places around here shut down. And there have been several that have stuck with the virtual, and they have liked it. They can work around their work schedules, and because there's meetings all hours of the day or night, and it has worked out really well for the ones I've dealt with.
Great. You know, one way to approach this, another way to approach this person is you need to find out a little bit more about why they don't want to attend recovery meetings. And that can be used with open dialogue and open-ended questions. An example would be, tell me what you know about mutual support programs. Really identify where they are in their knowledge and provide knowledge where they're lacking in some of that. Also, asking the person directly, tell me why these won't work for you. And what you're doing is really assessing the patient's strengths and weaknesses and what they need. Ask if they're spiritual, so that you can match a patient that is spiritual to a program that may work for them, or if someone's not spiritual, you may direct them to Mara or Smart first. Ask them what they know about behavioral therapies, and then refer them to the group that's going to best fit their what needs you think they have. Another way to look at this is find out what they know, ask all of the questions like we just talked about, and remind them, hey, if you have any questions or you want to talk more about it, please let me know. And maybe just bring it up at the next visit. So it's not that we have to force people and talk them into going to a meeting right at that moment. But really meeting the patient where they're at, giving them the information they need, and revisiting mutual support groups when it's appropriate.
Tom, that's a great point, right? Previous trauma or just previous bad experiences in groups, right? Help me understand, some of the issues that you've had in the past, or things that you've heard from friends or individuals that you're close with who didn't have a good time at a group. I would focus on the privacy piece, right? So I'm hearing that your privacy is really the biggest thing getting in the way of seeking out these groups. Are there other things that you feel like it would be a challenge going to a group like this, right? So using that sort of reflection and then open-ended question to try to move things forward in a very motivational, interviewing way. Yep.
Great. Carrie mentioned in the chat that she found some of the research that Andraka Christo and colleagues are doing on making opioid use disorder mainstream, medications for opioid use disorder mainstream, and she's done a lot of work in this field. So I encourage you to check out some of her research, and I believe left a link for a PDF file of one of her works. And yeah, that's great, Tom, asking about previous trauma and motivational interviewing like Dr. Oler was talking about. So there are lots of different ways to approach this patient. Any other comments? Okay, we can go on to the next scenario. So in this one, this is more of a case study discussing a few of the key terms and stigma that we talked about. So we had a 30-year-old male with opioid use disorder who is taking buprenorphine and naloxone and prevents for follow-up on his medication. He's been stable for 2 years and says the medication works really well for him. He lives in a sober living house and has been attending AA meetings for a year. He only discusses MOUD with his housemates, but he looks distressed when he comes in today. Someone informed his sponsor that he was receiving MOUD. His sponsor has been pressuring him to taper the medication immediately. Members of his home group now tell him he's not sober. He's frustrated because the NA community has been such an important part of his recovery. He is conflicted and says, I feel like I might have to stop taking buprenorphine or stop going to NA meetings. How would you all respond if this patient or client walked in to your office?
Yeah, I think it's really, really important first that to let him know that, you know, that I take him really seriously and that it's a very serious thing. And also, you know, with encouraging him to try again, you know, with a different NA or AA meeting, I think that I would absolutely give him all the information I had about MARA or smart recovery.
Okay. What about anybody else? Anybody else have thoughts on this? Has anybody ever had this experience before? It's a difficult conversation to have. Well, Nick and I talked about some approaches to this patient, and we can go over this. I think somebody just put something in the chat. Michelle put, validate his feelings, offer to assist him in locating a meeting site that is accepting of his treatment and what has been successful in recovery, as many meetings may practice or have different models. I think that's a great response. I think that's absolutely important, and validating feelings is something that we'll talk about in a minute. Anybody else?
I think this is also where you want to try to avoid this situation. They're going to happen. But from a preventative side of things, you can role play with a client. Hey, let's say, you know, let's hope that this doesn't happen, but what if your sponsor found out? How do you think they would receive that, right? That information that you are on MOUD, or, you know, if your sponsor says that I can't work with you because you're on MOUD, how would you go through that? So knowing that these are still, unfortunately, major issues for our folks who are on MOUD, the most important thing is upfront, beginning to have these discussions so that when a crisis occurs, you already have a game plan for how you're going to address it. So I think the validation of feelings, referring to another meeting, absolutely in the moment, but this is somebody that we're going to have to check in with pretty frequently to make sure that it's a smooth transition. And if not, we can pivot and move in a different direction for him.
Thanks. I think that's a great point, is having is prevention and having this discussion before it happens. That may decrease some of the anxiety about this happening by having a plan in place before it does happen. Next slide. So a few suggestions and ways to approach this patient, which I believe Michelle mentioned, validating feelings. We definitely don't want to dismiss the concern or discount this person's need for support. I think one of the traps providers can fall into is to immediately correct that incorrect information and say, oh, MOUD is definitely part of your recovery, and anybody that tells you otherwise is wrong. We take that approach, we might turn the patient off. So this initial part of the conversation of validating feelings is really, really important. And understanding that in our case with this patient, this group has really supported him in recovery thus far. And it sounds like since he's been going for a year and he's been in recovery for 2 years, that he's learned some important coping skills, made some friends, and expanded his support group. And so we don't want to negate all of those positive things that he got from the group. So definitely this is that key point when you can connect with your patient and say, you know, I've heard of this research. I know that this sort of thing happens. I understand that you're feeling really bad about it. The next part might be to use some open-ended dialogue. I understand that your sponsor feels you should not be on medication. How do you feel about receiving MOUD? Really letting the patient kind of talk through this thought process. We want to avoid yes or no questions here, because yes or no questions aren't really going to delve deeper into the problem. We can use some of our motivational interviewing techniques to help patient make their own conclusions about MOUD. Some examples of things you might say: tell me how your recovery has changed since you began receiving MOUD. Many patients, when I talk to them about this, will say, it's changed my life. I don't wake up in the morning thinking about how I'm going to get my prescription pain pills or heroin. And so highlighting these things that show allowing the patient to come to the conclusion about how important MOUD has been in their recovery. And then what would recovery look like if you stopped taking MOUD, and have patients go through that thought process of, you know, what would you be afraid? Would you be more afraid of relapse? What are your fears if you come off MOUD? And I think in that way, you're not necessarily telling the patient they should think a certain way. You're allowing them to come to their own conclusion. And the next part might be being knowledgeable about MOUD friendly meetings in your community. And doing some research for this talk, I came across several papers that mentioned, you know, as a provider, a peer support specialist, social worker, we should never really look at the patient and say, go to a meeting, just look up a meeting online and go to the meeting. That might be the barrier that keeps them from going. We should have a list of meetings, resources available for them, maybe a link to a QR code that has a list of meetings in their area. So take that piece that could be a barrier out, and share with your patient what meetings may be more helpful to them. We will be sending out next week with the newsletter a comprehensive list of meetings in the Wave 1 counties so that you can direct your patients to this list. And I think it'd be